Welcome to the Sports Medicine Orthopod, a show about the world of sports medicine and the people who inhabit it. My name is Anthony Yu. I'm pleased to introduce our guest this week, Dr. David Ring, a hand and upper extremity specialist from the University of Texas in Austin, where he is a professor of not only surgery and perioperative care, but also of psychiatry and behavioral health. David is also an associate dean at Dell Medical School, editor of two major orthopedic journals, and author of over 600 publications himself. David, thanks so much for joining. Welcome to the show.
Thanks for having me.
So you are from one of my favorite cities of all time, San Diego, and now you're obviously living in Austin, Texas. How did you make that transition? What was your journey like from San Diego to now Texas?
Yeah, I stayed in San Diego for undergrad and medical school because the deal was so good. California supported the education really well back then. I think I paid $1,400 a year undergraduate.
Oh, wow.
And $4,000 a year. Went up to $4,000 a year when I was in medical school.
Oh my goodness.
Now it's much higher, but back then it was such a good deal, and I lived at home and saved my parents a bunch of money. I actually did paper routes and worked pretty much since I was young and had enough money to buy a car and stuff like that. But I don't know, it's just very frugal. And how you like you say, you can't beat San Diego. But then in college, I met my eventual wife, and when we both liked traveling, and we kind of built our relationship on traveling. And then when it came time to branch off into our careers, we thought, residency was the next step for me. Let's try living somewhere else. And we went to Boston, which was not only the best residency I could get into, but it was about as far away from San Diego as you could get.
Yeah. Yeah. And not too shabby. You did your residency at a place everyone knows. Where was that?
Harvard.
Yeah. Yeah. No slouch there. And then you stayed there for a bit of your early career, and then working at Mass General, and then made your way to Texas. Is that right?
Yeah. So during my residency, I got interested in research when I was a medical student at UCSD. I had some great mentors. One of them was Alex Vaquero, who's now chair at Jefferson.
Sure.
He was Steve Garfin's fellow, and he kind of taught me the ropes of how to be very efficient and effective in research. And then, so when I got to Mass General, I met Jesse Jupiter. As an intern, you almost never see any attendings. You're on the wards at 4 a.m. or 5 a.m. and they're there at 9 a.m. or something. So
yeah,
the only one I ever saw was Jesse, because he was the only one that was up that early, and he was kind of overseeing the trauma service at that time and doing a lot of teaching. And I introduced myself, and he gave me some projects, and the relationship was off. And then by the time I got towards the end of my training, I just really, that's what I really liked everything in orthopedics, but I decided I would build on what I'd been doing, which was a lot of trauma, post-traumatic reconstruction stuff with Jesse. So I stayed and did his fellowship, and then stayed on staff, and then I was there for a total of 23 years.
Were you always interested in orthopedics even before medical school, or was that something passion developed?
No. I went to college, sort of like, but my parents said you could go to college and get a job. Oh, that's it. So I didn't ever think of what am I going to do with my life? You just go to college and get a job. And when you're in school, it's sort of like a puzzle. Like, here's how you get an A, try to get an A. And it was sort of a game. I was also interested in some of the stuff, and I liked math. And so I liked physics and stuff. So I got to college, and I applied to one college, UCSD, and thank God I got in. And then I can't remember. Oh, I said on my app, you had to choose a major. I was like, I don't know what. But we had just started learning how to use computers. We had a Commodore 64 at class, and I was learning how to program in BASIC. So I was, computer science. And then when I got there, a friend of mine who I was playing in bands with and stuff, and he was like, I'm going to do physics and math. And I'm like, oh yeah, I'll do physics and math too. So I ended up going that way. And then I had to I never took biology. I remember telling my mom, who was a nurse, she never practiced as a nurse, but she was RN, and then had kids and stayed home. But she she was, I said, I don't want to do biology. I'm not going to be a doctor or something like that.
Yeah.
I'm not, what do I need biology for? So then in college, I was required to take it. And I was like, whoa, nutrition, viruses, cancer. And, it was like, this is so important, all this stuff. And I thought I was really, because math and physics are important, but it's less tangibly important. So anyway, I switched my major. I was physics and biology, biochemistry. But I wasn't thinking about what I was going to do for my life. And then all of a sudden my senior year comes like, oh, what am I going to do next year?
Yeah, sure.
So I said, well, more school, that's what I'm good at, more school. And I did the GRE and did terrible on it. I did MCAT. I did the MCAT and also half-assed that and didn't do great on it. And I applied to everything late. So I didn't get any offers. I think I did one interview for graduate school and no offers. Mm-hmm. Medical school, I think I did like got invited for 3 or 4 interviews, all at places I would have to join the military to afford. And I said, okay, I blew it, but I figured out on this at the time when I was going through this, I figured out I definitely wanted to go to medical school because I wanted my daily work to apply my knowledge and help people directly. That's what I figured out what I wanted. I didn't want it to be like, okay, I did a bunch of work in the lab for 30 years and won a Nobel Prize and changed people's lives. That's also rewarding, but not the kind of rewarding I wanted. I wanted the daily interactions and the daily making a difference. So when I got to medical school, I remember getting in medical school. I don't know how much you want to hear about all this stuff.
Want to hear it all?
Okay.
Yeah.
All right. So I got to medical school by I was getting revved up to, okay, I'm going to take this seriously now. And so I studied and I retook the MCATs and did much better. And then I lined up a job. I found a job to do for the next year that would look like something. It was going to be at the Salk Institute. Actually, I lined up the job, and then I went to meet with the provost of my college at UCSD, and I was just lining everything up, getting advice, getting letters, doing it right, taking it seriously, like I didn't really do before. I didn't know what to do, didn't put thoughts into it. And then I got to the provost, and he's like looking through my application. He's like, picks up the phone, got me an interview, and I got in. I got in that year without taking a year off. So I had to say I'm not doing the job, and then I get to medical school, and I'm like, okay, I just scraped in. So I'm the bottom of the barrel. I'm gonna have to really work to keep up here. And then I started to realize that I noticed was that people were there for different reasons. So like there was people there because parents said you're going to be a doctor. There were people that said you're going to make a lot of money, even though even back then it was not people starting to complain about having a hard time making a lot of money in medicine. And then there were people like me that were like, I want to make a difference in the world. I want to do something good for people. Yep. I want my daily work to be meaningful. And I tell this story because I found that it's that sentiment that brings you forward. Like it doesn't matter how hard things get, but you can just, if you really are passionate about something, you can just keep going and keep after it and do, just try to do even a little bit better at things. So I just kept working and did well in medical school. But I was thinking of going into, I remember I like to travel, and travel when you're a college student is to mostly poor countries. And I did a lot of traveling to Mexico. Mm-hmm. Coming from San Diego, when I was in college, a friend of mine was going to go down to visit some of the people he worked with. And I said, I'm coming with you. So I was 19 and we took the trolley down to the border, went to the local bus, got to the bus station, hopped on a bus, and a day and a half later, we're dropped in the middle of nowhere in Mexico. And I just was, for upper middle class white male, it was just like, and I couldn't get enough. I took Spanish, but I took Spanish all the way through college even, but I didn't really learn to communicate until I was there with people that if I didn't speak Spanish with them, we were not going to be communicating. And so I went a lot of traveling in Mexico. My wife and I went to Brazil. We went to a lot of different places. And and I thought I'd do an infectious disease. If it's kind of like when the earthquake hit in Haiti and you saw what happens in what poverty. So in the midst of poverty, you have buildings that fall down. You have trauma like unsafe streets, unsafe cars, and then you have like cholera, HIV, and communicable diseases that we have under control. They don't. So it's like and it's the poverty. And that's what I was feeling the calling towards. And I actually reached out to. I remember doing learning tropical diseases, and I'm like, whoa, tapeworms and cysts in your brain, and I was like into it. So I went and met with the guy who did the tropical medicine lectures, because I was so jazzed about it. And I think if he had done a better job, like taking me under his wing, I'd be an infectious disease doctor today. Yeah. But what he kind of did was he said, why don't you go read this and come back later, So that didn't take off. And then the first rotation I did in, clinical rotations, it was sort of the summer after the second year. So like early third year, sort of, I did surgery first to get it out of the way, because I wasn't going to do it. Sure. Yeah, so I said, let me get surgery out of the way. And then I was like, I remember like my first rotation and my first clinical experience ever as a medical student, and I've been in hospitals volunteering and stuff, but you never really involved. And my first rotation was neurosurgery. The chief resident took every other night call. We would round at we'd pre-round at 4:15. We'd round at 5. We'd do conference. We almost never left the hospital before 8:00 at night. Yeah, and I just thought, that's how they all are. Yeah, that's how medicine is. So just sure. And people looked at me and they said, "Whoa, that guy, you should be a neurosurgeon." And I showed up in the morning, and I was the only one that didn't have a cup of coffee, but I was just as eager as anyone. They're like, "You need to go into neurosurgery," and they tried to coax me into it. But and then I went to I thought those guys were like self-sacrificing themselves. And I went to general surgery, and there was just a bunch of dicks, really. I mean, and then I went to orthopedic surgery, and it was like, my kin, they love what they're doing. They're like so excited. They really love what they're doing. And, somebody would come in with a broken femur, which is a real bad problem. And then you think, and they get up and walk the next day. And I was like, yep, that's it. That's what I want to do. And it was really, it was more, actually, I should give more credit. That was when I was awakening to it. But just like when I got to college and followed my friend into physics and math, there was a fellow medical student who was a former physical therapist, Julie Long, and she's a spine surgeon in Maine now. But she was like, I'm doing orthopedics. I'm definitely doing orthopedics. And she was so enthusiastic about it. I was kind of like, she drew me in. So that was really a big part of it. I thought, you know what? I really like it. And her passion rubbed up on me. And I know how this works, because I've done things half-assed before. And this is competitive, so I'm going to take it seriously. So I started, I think I did, when we could do fourth year rotations, it was a little bit early in the year, and I did orthopedics first. And that's when I met Dennis Wenger, my first mentor. And he gave me a project to do. And that was the discitis work that I did with pediatric spine infections. And we took a careful look at it and decided that discitis was a misconception. Like, it's actually just vertebral osteomyelitis in kids. Yeah. And we showed that based on MRIs and misinterpretation of negative cultures, and so it was like the first thing that I deconstructed. And I remember when I was still working on all this when I got to Harvard. So I went to Countway Library, which is this famous medical library, and you go down to the basement, and there's these stacks of books with dust all over them, and they literally go back into the 17 and 1800s. And I read everything written about discitis. I was the world's expert on discitis, having never treated a patient. That's sure. One of the gaps. Yeah. But I was the world expert on what was written, and I was pretty sure that we had made some errors in how we interpreted the data, and that some people had said certain things that became gospel and then turned out to be wrong. And I just deconstructed it all without a thought. And Dennis was like, what the hell? And, it's like, and he said, you basically just got a PhD in discitis. And I remember we wrote something in what's now called the American Journal of Orthopaedics, but I wrote this review of all this stuff I'd come up with. And we put it in, it was called Orthopaedic Review at the time. And it was just, it's my manifesto of like, how did we get it wrong? Right. And, that's basically how the rest of my career went is sort of like, don't take things at face value. Sure. The mind is imperfect, cognitive bias. There's all kinds we make mistakes all the time. And there's nothing wrong with that. I mean, that's like, actually that's expected, but once you see there's a mistake, don't be too shy to kind of correct that mistake because you'll help people. So that was, that's how I ended up in orthopedics. That was the start of my research interest and the start of my curiosity. Then Alex Vaquero taught me how to be efficient and effective. And then Jesse just fueled me and built my career.
Sure. And I mentioned at the top in your current, where you're at University of Texas, you're not only a professor of surgery, but also of psychiatry and behavioral health, which to the audience, this is not a classic combination. This is not like mac and cheese. Orthopedists are known for a number of things, but being in touch with feelings and emotions, not so much. So how did this come about?
Yeah, so it's a pretty good segue from what I was talking about. So when I was with Jesse, sort of in the 90s is when what we now call patient-reported outcome measures came out. Back then they were called health status measures. And SF-36 was the one that was sort of getting out there. And there were some predecessors like the Nottingham Health Profile, which Jesse had actually used. And we started using SF-36 a little bit, playing around with it. But then right at the end of the 90s, which was the end of my residency, when our research machine was established, Jesse said, we got to start using the DASH. The DASH had been developed by the American and Canadian Orthopedic Societies and was now released for use. And Jesse's perspective was, when we try to put our studies in the top journals, they're going to require this now. So just like we do range of motion and grip strength on people and take x-rays every time so that we can go back and look at the chart and write papers on them, we have to have the DASH scores in there. So we'll have that data. Otherwise, they're not going to let us in the top journals. That was his thinking. So we just started giving the DASH out to everybody. Mm-hmm. And I think at some point I decided we had stacks of these paper forms, and I think I had some research people looking for research projects. I had them type them in to a spreadsheet, and I just started playing with the data. And that paper became that playing around became this paper called Idiopathic Arm Pain, where what we did is we looked at the mean DASH score for various diagnoses and showed that non-specific pain, meaning no signs of pathophysiology or impairment whatsoever, was actually a sort of middle-of-the-road DASH score, worse than a lot of fractures. And that's basically what that paper said. But in the process of doing that paper, we had all these histograms. And so there's this histogram that I show in talks that I give to this day that shows the distribution of DASH scores. And there's a sort of a bit of a floor effect where people are doing really well. And then it goes all the way up to a score of 80, which is like I say, it's like a burning stump. Your arm is useless and it's on fire. And this is a single trigger finger. This is 68 people with a single trigger finger. So you look at that histogram and you're like, there's no way that pathophysiology explains that. Mm-hmm. That variation in the subjective aspects of illness, of symptom intensity and incapability. And so I started talking about that and studying it. And I put a ad out for Harvard medical students. Harvard had this program where if you paid, they'd actually help. They pay part of medical students' funding, and you pay the rest. So it was an affordable way to get somebody motivated to come help. And I put this ad out, and it was on the internet. So this person from Dartmouth saw it, who was a psychology undergrad and heading to medical school and wanted to do a gap year. And she came down and we started talking. And she basically told me, like, I said, what is it when people write like a bunch of narrative all over the dash form? And she said, oh, that's called neuroticism. And we measure it with this. And I said, well, what do you think's going on when this happens? And then she said, oh, that's, heightened illness concern or hypochondriasis. What about that? Oh, that's probably symptoms of depression. And you can measure that with this and measure that with this. And I said, you're hired. Let me find some money. I don't know where we'll get the money, but you're hired. So we found some money. We had an AO grant and I had to get somebody else off of it, get her on it.
Yeah.
And she said, look here, look here, look here. And that became papers like I forget what it's called, but the early one about depression and DASH scores. And it was all there. She just said, here's how you measure it. And it just fell out. So I started just pursuing that line of research, and it really was recapitulating what had been done for back pain and others. But the instruments were a little bit better. Like you went from this sort of Minnesota multi-phasic personality inventory to something very, very specific, like symptoms of depression or catastrophic thinking, pain catastrophe scale. So we started to measure and get very specific. And then I realized that I needed somebody to collaborate with other than just this, future medical student. And I reached out to our behavioral medicine department in Mass General, and Steve Safran, who was a very successful researcher, said, yeah, this is great. We have somebody in GI, we have somebody in cancer, let's put somebody in musculoskeletal. So he hired an intern, a psychology intern, and she sat with me and worked with me in a hand clinic. And then she became a postdoc and did her postdoc with me. And then she stayed on with me and actually saw patients on our unit. That's Anna Maria Ronchanu, who's on a lot of the papers that we still do. We still work together a lot. Mm-hmm. So there was that going along. And then it just, I guess when I got to, it was the most fruitful area of research, and it was the thing where I think we needed the most, we could make the biggest difference for our patients. So I just kept pursuing it. By the time I got to, then I ended up in Austin because there was my interests are a little bit against the grain in terms of the business of orthopedics. Uh-huh. So becoming a chairman of a department was kind of what I wanted to do and kind of what I thought would be difficult to do, because I'd be answering to the person that runs the health system, and it might be a little distasteful for me, and it might be distasteful for them to hear me speaking. Although I think the way that I think has been proved time and again to be predictive of how the future goes. So I do think, like, the way we talk about comprehensive care and biopsychosocial paradigm it fits so well with alternative payment models. And I just think it's a culture change that we're going through. And but as soon as we make that shift, you'll see all these things get implemented that we're studying and talking about. But right now it's not within the payment models. But so I kind of saw an opportunity to come to a brand new medical school in Austin where the dean was saying, let's rethink everything. And I thought, I'm not going to get this chance again. So ended up coming down. And when I got here, the chair of psychiatry, turns out, well, this gets to music, which I know you found that I play. So the chair of psychiatry came like about 4 to 6 months after I did. And we kind of immediately figured out that we both played music. And then pretty soon we were in a band together. And I don't know, he somehow figured out that I did a lot of research in psychology and said, I'd like you to be a courtesy professor in our department. Uh-huh. I didn't know what that was, but that's a thing. Like we have engineering professors that are courtesy professors of pediatrics, or courtesy professors of surgery, because they do a lot of stuff that overlaps. And so he said, this would be good for my department. And I thought, that would be great. It's something I'm really proud of, actually. I had to figure out how to list it so it's not misleading. It is appropriate to say professor of surgery and psychiatry, but the full title would be Professor of Surgery and by Courtesy Psychiatry would be the more appropriate one, and probably a little bit less prone to like people think did a psychiatry residency or something.
Sure.
But that was, yeah, I mean, it was nice of him to think of me for that, and nice of it takes a little effort to push that sort of thing through. So and when I had that, I was like, you know what, that feels like I really like that. I really like that recognition of the impact that we've been able to have.
Yeah, and it's not like you watch like Good Will Hunting and you're like, oh, I understand mental illness all of a sudden. That was like interesting. You actually earned a PhD in psychology, correct?
Well, yeah, and that's a little bit different too. So the PhD is a Dutch PhD. So there's several different types of degrees you can get in Europe and the UK and around the world that and they're degrees awarded for clinical research. So there is nothing like that exactly in the US. When I left Harvard, they were starting to put together a master's program that had that. But there's no PhD degree for clinical research in the US. But in Scandinavian and Northern European countries, there is. And you know I could tell when I was doing all that research in Cantway Library when I was on to somebody's PhD, because you'd see like the same person, the same name, publish 5 things on clavicles and then 5 things on elbow fracture dislocations. So I knew that it existed, but it was something you did to advance your career when you were already in an academic position. But what it became starting in the early 2000s was a way for medical students to get into competitive residencies. So if you're a medical student in the Netherlands and you want to get into orthopedics or plastic surgery, and you go to plastics to be a hand surgeon. So I would get plastic surgeons coming to me and orthopedic surgeons coming to me, and they would do 2 years of work and get a full PhD. And my first PhD student, Jaap Dornberg, said, "Why don't you have a PhD?" And I told him, because we don't have anything like that. He said, "Well, what about getting one from Amsterdam?" I'm like, "Sure." So we asked Nick Van Dijk, who's a big sports guy. He's a foot and ankle sports guy, takes care of like Ronaldo and the big soccer guys there.
Yeah.
And Van Dijk's like, "Yeah, sure." And then I gave him a couple of themes. I gave him like non-union. I gave him elbow fracture dislocations. And then I said, "Well, I'm also working on this new thing. We're kind of, we're finding a lot of stuff in mental health." And he's like, "Let's do that."
Yeah.
Which again, I was like still shy about it back then, because, you talk about that stuff and, I'm not a naturally good, I'm a surgeon, so I'm not naturally a good communicator. I'm pretty blunt, matter of fact, and goal oriented like most of us are. And so when I was trying to talk about mental health, whether it was with my patients or with my colleagues, it didn't come out. Like with patients, it came out like, the stigma hit them, like, like you're flawed, you're broken. That's what they heard, or it's all in your head. And so I had to become a better communicator. That's how I got interested in communication strategies. And then with my colleagues, it's like, you're saying all your patients are crazy. You're a zealot. You're trying to convert us. And it's like, no, yeah. I thought I found something interesting, but I didn't communicate it well. So I came off wrong. So so that was, trying to figure out a way to I guess, to get this excited. So I was really happy when he chose that, because I thought, okay, that's great, because he's gonna be my promoter, and he's gonna edit me.
Yeah. Yeah.
And I know him a little bit. He's pretty biomedical minded. I'm going to get a good critique here. This is going to be a good experience. And it was super good. He pushed me on all the things, all the things that people were pushing back on. I had somebody to go back and forth with in an academic setting, but it really was more of a recognition of research I'd already done, and there was no coursework or anything. So it's a Dutch PhD. It's not like a US PhD.
David, it's a PhD. You're a professor of psychiatry. We'll just leave it at that. You have a recent editorial in a major orthopedic journal. It's called the Journal of Bone and Joint Surgery. For the audience, that's like, variety for the film industry. It's the bee's knees. It's a big deal. It's Ron Burgundy. And you talk about this in this editorial, the connection between mental health, societal health, physical health. And one of the interesting points you bring up is that one of the problems with mental health is just recognizing that it actually exists, that it's actually an entity. It's kind of like, how do you expect to understand or treat this disorders of the mind if you don't even acknowledge that it exists, that it's actually a thing? Elaborate a bit on that.
Yeah. So that editorial, the pandemic hit, and then we had the killing of George Floyd, and of other prominent killings of Black people by white authorities. And so we were having these two really important discussions. There was one about how to handle a pandemic. There's so many layers of that, including inequities, health inequities, and disparities. And then there was anti-racism. Mm-hmm. And most of us really leaned into that. I know. I over the summer I took this course that was offered. About 3,000 or 4,000 of us did an anti-racist course done by one of the vice presidents at UT Austin. There was a reading list. I was reading. I read White Fragility. I read a lot of great stuff. And in the meantime, I'm submitting stuff to JBJS, which, by the way, I took a pause from submitting to them. A lot of us did when they started charging for submissions. So, like, as a reviewer, I review for free, and then you charge me to submit. Nah.
Yeah, right.
I said I'm not playing ball with that. And I guess about a quarter of their top reviewers did the same with no coordination. We didn't get together and talk about it, or we just said, nah, that's stupid. So Mark developed this thing called the Elite Reviewer Program. So if you do a good job and you're timely, you do a lot of reviews, then you can submit for free. So I got that, I earned that, and then I started doing a lot more submissions. So we got a lot of stuff going in JBJS, and a lot of it's mental health related or communications related, or we got a lot in. I mean, last year was good. There's been some really good stuff that we got in, and that's credit to Mark and the editorial board. But then there's a whole bunch of stuff that didn't get in, and a lot of times the editors and the reviewers would say not relevant. Publish this in a non-orthopedic journal. And I emailed Mark and I said, I know you don't believe this, but this has got to be difficult for you when you have reviewers and editors that don't get it. And he's like, yeah, it's super hard. Yeah. And I said, it's not dissimilar. It's a culture change thing, and people say, what about white privilege? What are you talking about? So they need to like figure that out and start to operate in that universe. And I think it's the same thing with mental and social health. There's so many incentives for us to not pay attention to it. Sure. Yelp reviews, first and foremost, as I mentioned, it's a difficult topic. And so it's role modeled to you, and it's in all the journals, all the lectures. I mean, you just completely ignore thoughts and distress, misconceptions, misinterpretation of symptoms, distress about symptoms, insecurity in your roles or your housing or your job or your relationships or your financial food security. You just ignore all that. Like, my job is the bone. I put the plate on the bone and that's it. Right. And the truth is that, this we need to reframe things, I think, to get people's attention about it. For instance, shared decision making. People, I do that really well. I'm always sharing the decision with the patients. And it's like, wait a minute. We know that's not true because there's so much variation. Like, if a patient goes to different surgeons, they come out with a different treatment. So that you're definitely not sharing as well as you think you are. So they started to change up that discussion by describing it as misdiagnosis of the patient's true preferences. Not their immediate preferences might be based on misconceptions or false hope, but their true preferences based on what matters most to them or their values. So it's that I love that framing, to put a quality and safety frame on something that, people think it is sort of an aspect of care that they think they're naturally good at. Just like communication strategy. Most of us think, oh yeah, I mean, I'm smart. I got to this point. Like, I'm the cream of the crop, so I've got to be good at that too. No. So I suck at it, and most surgeons do. We're terrible communicators, so we need to work at it. Work. So that was, and I thought, this is a culture change moment where we're trying to bring people around, and so the quality and safety moment is, again, misdiagnosis. So if you're an orthopedic surgeon, if you're a musculoskeletal specialist, you are in a special position. Non-specialists cannot discern disproportionate symptoms or disproportionate incapability, they don't know when it's more than what you would expect for the pathology. Like, so if you get a KO grade 1 knee and somebody's hobbling and not going to work and stuff like that, and not doing their life roles, not sticking with what they enjoy and their livelihood, then you know that there's a disconnect there. But most people will not. So you're the only one, or you're the best placed, let's say. You're the best placed to discern that and then notice that and diagnose that. So what we want to do is we want to make sure we have timely, accurate diagnosis of misinterpretation of symptoms, the most common being hurt equals harm. I can't be myself as long as I have this problem. There's a whole list of them that are in the negative pain thoughts questionnaire that came from Anna Maria, and I put that together way, way back when we're just listing all the cognitive errors or misconceptions that people bring to us every single day.
Sure.
And then there's distress, either distress about symptoms or just distress in the midst of symptoms. And distress is worry and hopelessness or despair. So depression and anxiety. So there's that. And then there's social aspects of, like, let's say you're a 55-year-old laborer, and your body, it's hard to be a laborer as you get into your 50s and 60s. Yeah. And you may not have a plan B. You may not have education or know what you're going to do next. So that's an example of role insecurity, financial insecurity, housing insecurity, relationship insecurity, if it's family and wife. And so all those things come in, and we are the ones that can diagnose those. We are an emergency room doctor, occupational medicine doctor, PCP they're not going to maybe have the confidence, but if we can make the diagnosis, coordinate with the other doctors that have a good relationship, we can get them the care that they need. And those are the cards I really enjoy. Is I get a card a year after, and it's just out of the blue. Dr. Ring, you took care of my metacarpal fracture. Thank you so much. But you really changed my life when you helped me notice that I was experiencing a lot of anxiety, and my anxiety is under control in my life. It's a miracle how it's changed my life. And the metacarpal fracture didn't even need a doctor. I say that passes the cave person rule. Like, yeah, it didn't need X-rays, didn't need a doctor, didn't need cast, didn't need anesthesia, didn't need antisepsis. All the people that punched rocks when they were angry, they're in the fossil record. They survived just fine. So, what that person does need is compassion. They need to trust you, and then they need guidance, because the recovery process is so fraught with pitfalls, like feeling you shouldn't move your hand because it hurts to move your hand, and so they need to be able to trust you when you encourage them to rethink that and move their hand. So it's mostly about building trust, building relationship, effective communication strategies, effective relationship building. That's the priority of every visit: is soothe, not solve. The medicine is going to be easy, or it'll be impossible. Like non-specific pains can be impossible, but you don't know what's going on. But most of the medicine is easy. It's easy to diagnose, easy to know your limitations. But creating a trusting relationship is really, really hard. Particularly the more anxiety a person is experiencing, the more despair a person is experiencing, the more they kind of look internally, and it's just really hard to get a good relationship. And you can be really good at a really good communicator and not make much headway there, but you can at least show compassion and do no harm. But that's I think the key things I've figured out is to have good communication skills, make a good relationship so you can make the right diagnosis and prioritize mental and social health. We will take care of the physical part as we do. We do a good job, but we can't neglect that aspect of it.
Yeah, and that neglect, these pitfalls you mentioned, they apply to all aspects of our culture, including the world of sports, particularly with athletes, right? So athletes are taught to be mentally tough, to be strong, shake it off, put your head down, suck it up, get the job done, don't complain. But that's starting to change a little bit now. We have, Kevin Love in the NBA, DeMar DeRozan in the NBA, and now Naomi Osaka, this ongoing story with her. Athletes are starting to come out to talk about their struggles with mental health disorders. What do you make of this pretty monumental paradigm shift?
Yeah, I've been loving it. The military as well has made the shift. I remember this goes back to when I was in Boston. So it was Yankees, Red Sox, and Chuck Knobloch got what they call the yips, and he was playing. He would throw the ball into the ground. And he got a sports psychologist, came back, and I just loved the way that was handled. I don't even think I don't think I'd gotten very far along in this journey at the time, but I was like, that's important because, and I didn't know what social stigma was, but I knew that it was undoing that. Social stigma is the othering or lesser than. So if I say psychology or depression, we immediately recoil from that. Not me, I'm fully human. That, if you're depressed, then you're not fully human. So what the athletes said is, and the military said is, are you kidding? Look at the situations we put ourselves in. How could you not have mental health issues? I mean, you in fact, every day you are working very hard on your mental health just to get as good as you are at your sport and to continue and compete at that level. It's actually when you maybe you're not doing as well at what you do so well every day that so much is asked of you. And I think the military is the same way. They realize, like, if I'm going to send people off to war and they're going to get shot at or shot, then I shouldn't be surprised if they get affected by that.
Yeah.
And so there's this very open discussion. There's the military does resilience training. It does it's got positive psychology going on. It's really great to see. It's this culture change, or you have to foster it and you have to protect it every day. It's something, if you let your guard down, your natural tendency to separate mind and body and then stigmatize the mental side. There's something it's something about the way the human mind works that happens, and you'll just default to that if you're not working constantly to be intentional about being open to unhelpful thoughts and unhelpful emotions, and that they're normal, that we all experience them. And sometimes we experience them to the point where we need help.
Yeah, you mentioned this stigma with something like depression. Certainly in our society, and this is not just an American thing, it's global, mental health disorders are a source of shame, a source of embarrassment, not something that is openly talked about historically. What do you think it is about this generation that they're becoming more comfortable with sharing their personal stories, as somebody who's kind of witnessed mental health over the last 20, 30 years in this country?
Yeah, I still think we have a little ways to go, obviously, but I do think, like, I do feel like it's at least a topic that we can discuss. Like, it used to be really taboo. Mm-hmm. And actually, there's a lot of ways that we messed it up. Like, for instance, pharmaceutical companies wanted to sell drugs, so they told you it's an imbalance in your brain chemicals. And this is going to get outside my expertise, but there's a lot of debate about that. And that it actually is more of a tendency towards negative affectivity, which is like thinking worse, interpreting things in a worse way or negative way, and cognitive fusion, which is when thoughts are not possibilities but facts. So you fuse with your thought as if it's reality. So those are sort of where a lot of distress, depression, anxiety is thought to come from. But they taught us it's a brain disorder, it's medications, and there's probably something to that. Although schizophrenia and bipolar are more genetic than anxiety and depression, as far as I can understand it. And then there's another aspect of it that we talk about. If I say anxiety or depression, we think of the diagnosis of, and we really ought to be thinking about the continuum. Every morning when we wake up and our mood is in some place. Like, if you had a bad dream, your mood might be a little bit down or negative. Or if you let's say your surgery didn't go that well yesterday, you probably wake up and you feel a little bit, deflated, a little bit despairing, a little bit. And so every day your anxiety or depression is at some level, but there's always some of those feelings, some small amount of those feelings, and sometimes there's more. And so we should be talking about the continuum on which we experience distress and the continuum on which we misinterpret things or experience misconceptions.
I want to focus a little bit on Naomi Osaka and what just transpired at the French Open and subsequently from there. So as everyone knows, this past May, after her first round victory, she missed a mandatory press conference and then was subsequently fined $15,000 by the tournament. This sparked some debate, some offering support, some offering some kind of veiled criticisms. And shortly thereafter, Naomi Osaka drops out of the French Open. This is tennis's arguably biggest star at this point. What were you thinking when you watched this all play out?
Well, again, like you said, I'm super happy, and I was impressed by her saying, "Hey, I have anxiety, and this is what going in front of the press feels like to me." Mm-hmm. I mean, that's the discussion. We should have that discussion more and more and more. And we all should be able to talk about the time that we felt that way. And then realize that if you don't, we're lucky if we don't have those symptoms get up to a much higher level on a regular basis, like people who take the diagnosis of an anxiety disorder or depressive disorder because of it causes them to be dysfunctional or limits what they can do at times. So I was really, really happy about that. I felt like my sense was that there was some culture that was keeping her from, like, she had to say that after she didn't go to the press conference kind of thing. So I saw like that's kind of where we are, I think, in our society. Is she doesn't start off every press conference by saying, I'm feeling pretty good today, but this is difficult for me. I'm thinking I could take about 10 minutes, maybe 5 or 6 questions, and I'm going to ask for you to honor that, something like that. It's like just be way up in front with it.
Yeah.
So it's kind of like doing a checklist, like a timeout just before surgery, and not just like going through the motions, but saying, "Hey, I make mistakes. I will make a mistake. But so can you guys all help me and catch my mistake?" Sure. Yeah. So it's kind of like I'd like to see that. It's like I am a high profile athlete with an anxiety disorder, and please honor that and respect that, and don't just don't be insensitive or dismissive or want it to fit only your vision of how this should play out.
Yeah, absolutely. And I think most people have somebody in their life, whether it's a friend or loved one or themselves personally, who has suffered from a mental health disorder in some capacity. But when it happens to somebody like Naomi Osaka, or where there's this admission, it still comes as a shock, right? Because we view these people as superhuman. She's young, she's on top of the world, one of the best in her game, she's rich, she's got the world in the palm of her hand, and it seems, inconceivable that this would affect her because she's just got everything going for her. But at the end of the day, these are people. They're human beings with emotions and feelings, right?
Yeah, and my younger brother has had major depression off and on, and my daughters get anxiety. So I tell my daughter, I say, I'm not that different from you. It's how I've channeled these feelings. And you think about I told you about becoming, people wanted me to be a neurosurgeon. Like, what was it that made me think that was a reasonable way to live? Like that you would be, 4 a.m. to 8 p.m. and then you go home and study for the conference the next day, by the way.
You're glad for punishment.
Yeah, and that was what medical school was going to be like all the way through, and that's what my life was going to be like the rest of my life.
Right.
That I was okay with that. That's pathological. And then who does the amount of research that I do? Like my daughter used to say, "You're going to marry your computer." It's a workaholism, right? It's I'm channeling my anxieties, my existential crisis by trying to do things that are fulfilling and meaningful and purposeful. And that actually ends up being a key aspect of health, is having meaning and purpose in your life. So when you wake up in the morning, and no matter how you feel, you got somewhere to go, something to do, somebody needs you. So you hit the ground and you shake it off and you get to work. And you see people, we see our patients all the time. What the reason they're in our office is because they've lost a cherished role. Sports is classic for that. There's so many people that in high school and college are self-defined athlete, and then that starts to change. Or let's say you're getting into your 60s and 70s and you can't do triathlons anymore, and people lose a part of themselves, and they'll do anything. They feel like it's fixable, and that if you fix the knee, everything will be back like it was before. And that's a huge opportunity that you don't want to miss. Like, you don't want to just give somebody a steroid shot or get an MRI or scope them. When the real journey is to evolve their identity. That's what they're doing. They're evolving their identity. And people do it all the time, successfully do it, gracefully do it. But we often see people when they're at a moment where they're stuck, where they're having trouble getting one step, okay, I can't do it like I used to do it, but I can still do it, kind of thing. Sure. They're having trouble. So if we can help guide them, a lot of times they don't really need much from us after that.
Yeah. We see that a lot in the sports medicine side, as particularly with something like an ACL surgery. What we know is that surgeons, by and large, are pretty good at restoring the stability to the knee with an ACL reconstruction, but studies are showing that maybe only 50-60% of these athletes, weekend warriors, people of all ages who get an ACL surgery, are going back to play the sport of their choice. And there's a lot of psychological factors, maybe first and foremost fear, which is not something you or I can control. And I think our role is to sort of lay that out for the patient, that, we're going to give you this opportunity to pursue your goals and make your knee safe for you to play basketball if you want. But if you end up not wanting to, that's okay. And that's very common. It's not something to be ashamed of, because it's just the way we react to certain things. Some people get scared about hurting themselves again. Some people are just kind of done with it, and that's okay.
Yeah. And also, if you I like what you're saying about, it's okay to not be soccer player anymore. Now you can be engineer or dad or, golfer. That's something that people need to hear and need to know, because they don't give themselves permission sometimes, or even realize that there's an option. But there's another thing, and that's back to the sports psychologist and such, that you don't have to accept the story your mind's telling you. Mm-hmm. So if you just say, like, painful activities are harmful, done, or if I play soccer again, I will definitely re-rupture this ACL. I can't go into that side tackle as hard anymore. That's the story your mind's telling you. It's not true. You can rewrite that story. And there's athletes are used to. I tell people, like, if you wanted to learn a new sport, you'd get a coach, and they teach you how to do it, and you'd practice and practice and practice and practice. And it's no different with your mind. If you want to know how to work your mind, you need to have a coach, and then you have to practice and practice and practice. And it's just as hard, if not harder, to control and channel your thoughts and tell a healthy story. But that's what things like cognitive behavioral therapy do. It's like there's a whole lot that goes into the ACL is a good paradigm. Mm-hmm. So my wife ruptured her ACL skiing. She's probably, I think she was in early 40s, let's say 41, 42. And, that gets so, like, you're just about to hit your arthritis years. Do you really need to be replacing your ACL? And so she's like, I don't know if I want to get it done. I told her, I didn't try not to be a doctor. I just said, your ACL is for pivot sports. If you do yoga, you don't need one. Right. Because yoga was her other thing. If you want to keep alpine skiing, maybe you want to do it. And then she went on Facebook, and all her friends like, do it. do it, get it done, get like 50 people. And then one of my colleagues actually calls her up, didn't want to scared to post, like the momentum is so strong for surgery. Calls her up and says, you don't have to have this done.
Yeah.
And she kind of thought it through. And then as she started feeling better, right, as the pain goes away, your thinking clears. And then she decides, let me see what I can do without it. Mm-hmm. And she even alpine skied a little bit with just a few pivot experiences. Everything else in her life was fine, except for once in a while we'll pivot, like walking on rocks or hiking or something.
Sure.
And about a year after deciding not to have surgery, she's like, which knee was it? I can't remember which knee it was. And it's she's never regretted the choice. In fact, we think because she had a knee injury skiing about 10 years before that, we think she probably has no ACLs on either knee.
Now she got a matching set.
she's doing fine. And so this whole idea, if it's broke, fix it, is wrong. And you can, she decided to evolve her identity. So I'm not going to alpine ski anymore. I'll just cross country ski and do yoga and do other things. And she did alpine ski a little bit, but then we gave it up. And that was okay. And she was happy to evolve her identity, and it made it easy to avoid ACL reconstruction.
Yeah. Getting back to Naomi Osaka. So we've recently learned that she's going to skip the next 2 tournaments, the second of which is Wimbledon. It sounds like she's planning to play in the Olympics. In the show, we talk a lot about these soft tissue injuries. The NBA is full of them right now during the playoffs. And a lot of these have no real timetable for return. We as orthopedists kind of throw out these timelines. We don't know if they're real. It's just very individual. We don't know when Kyrie Irving's going to recover from his ankle sprain and when he's going to be ready to play NBA level basketball. The mind is similar, right? It's an injury of the mind, mental health disorder. We don't know. And it's great that Naomi Osaka's taken that time to get herself right. Because there is no timetable for these, right? It's very individual.
Yeah, I know that you and I both had a similar idea of taking news reports about sports things to teach people about health. And I would always love these, like they would say, like, somebody obviously has an ankle sprain or a groin pull or a hamstring, and they're going to get an MRI. It's like, cut it out. What the? You're teaching everybody bullshit medicine. Like, so we can cuss on this thing. But, you're just, like, everyone now thinks they need an MRI for everything because Absolutely. Of that. And so, they say it'll be so many weeks until they can get back. So, like, let's say they had surgery. I remember when the Philadelphia Eagles played the New England Patriots in the Super Bowl the first time, and Terrell Owens broke his ankle and had surgery, and he's like, I'm playing. And like 7 weeks later, people were writing about whether he should play or not. And no, he puts that bone's not healed completely. The ligament's not healed completely, and he's asking them to do a lot. So he's definitely putting himself at risk, but it's a risk that he was willing to take. That's fine. So I thought that was pretty well discussed. Like, there's risk. He has the risk tolerance. And so far, I thought that was a good discussion. They don't usually have that discussion. They just say 7 weeks and it comes out of nowhere, or 8 weeks. And then with the soft tissue ones, it's the same thing. Really, it's about being effective, right? Because if you pull a muscle, you're not at any risk when you play.
Right.
It's really about being effective. James Harden, he's trying to be effective. He's not as effective.
Yeah.
But as soon as he's comfortable enough, and your mind can take you a long way, like the virus game of Michael Jordan. Your mind can take you to the next level with your inner pharmacy. Mental health is definitely the same way, because if you could just take a pill or do your mental exercises, and if it was easy, it would be easy. So it's not. And I think, asking for space and being given space, that's important.
Yeah, absolutely. So, we'll see how things play out with her. I'm sure she will return to the court when she is ready, and that's the appropriate thing. You mentioned in that editorial that sort of the classic orthopedic response to mental health is this doesn't apply to us, but things seem to be getting better. And it seems like every month in every major journal, there's an article that's linking underlying mental health disorders to challenging or even poor outcomes after surgery. How have you observed this maybe acceptance or kind of eye-opening from our own field to mental health as a really serious factor to consider in our patients?
Yeah, it's been really gratifying to see this come around. I mentioned how that editorial came about. One of the things I do a lot of peer review, and I'm on some editorial boards. And so I know all the journal, and they're my peers that are the editors of these journals. So I know them all personally, and I work closely with them, and they all get it. In fact, I find them, I'll just shout out to two in particular, Brent Graham at Journal of Hand Surgery and Seth Leopold, who's amazing at Core. And those two, they do so much extra work to help me find the words that will resonate with people. And I think they do it for others. But they get it. They want that stuff in their journals. They know it's important. They know it's going to help people get better. So the editors get it, and a lot of reviewers are coming along. It's coming along, and it's really gratifying to see, because it's, like I said, it was uncomfortable for a while. Like I felt alone talking about it. I felt pushed outside. I own it. I didn't talk. I could talk about it better. I could come off better. I definitely had a lot to learn, and I keep getting better at it. But it was very easy to get marginalized, and now it's more mainstream. I'll give you another example of this. The Hand Society, American Society for Surgery of the Hand, has a listserv. So it's this sort of shared communication space, and people post their cases. I post cases there. I tell patients I'm going to get some help, and I post it. And I first went on there. When I first went on there, I tried to talk about science, like steroids don't do anything for tennis elbow. And I tried to talk about the role of catastrophic thinking in something like tennis elbow. And I just got burned up. They did me in. And I realized that I just did not have the communication strat. I was kind of probably, self-immolating by just doing it wrong. So I pulled away for a year. I pulled away. It was about a year. I was going to pull away until I could talk about things better. And I went back on with, I thought, okay, I think I've got better words now. I've got better ways of talking about this. And I went back on, and then I had some different strategies as well. And now if we look at the listserv today, there's definitely a community of people that are like, yeah, what he said. And they'll like actually lead. Like sometimes I don't even have to say anything, and they're in there talking about these things. So I've seen the evolution, and I think it's because, if I were to say there's the reason is because these people now regard this as tools to help them enjoy their work better because their patients do better. So what used to be resentment or feeling disrespected now becomes part of the patient's illness, and it's just a matter of compassion and trying to be better able to communicate and connect with them and not taking it personally. Where you would feel painted into a corner to get the MRI or do the shot or do the surgery, you now realize that there's actually an ethical imperative sometimes for you not to do the surgery, and that you can rest on that ethical imperative and not feel like you're denying the patient or letting them down. I mean, if you ethically if it doesn't feel right to you, don't do it. That's your ethical. And you can tell people it just doesn't feel right to me. My ethics, my morals say I should not do this. If you can be patient with me, we'll see what happens down the line. I'm not taking it off the table. I just really want to honor this feeling I have. And it's hard for people to get mad at that. They still do sometimes, but it's much harder for them to get mad at it when you phrase it like that. It's like, I just want to do the right thing. I'm just really struggling here to do the right thing. And I think those are when you bring people tools that make their life better, and they enjoy their practice more, and they enjoy their patients more, I think that's when it starts to resonate. And that's, one example. An example of this could be the opioid epidemic. So, having discussions about no more opioids is a relationship threatening moment, and particularly life or violence is like, people have gotten shot over this sort of thing. And so what we came up with was tools the AEOS pain alleviation toolkit that's now co-branded with ASA, the anesthesiologist. It gives you all these tools for how to like depersonalize discussions and get ready people for surgery. Don't sign up for discretionary surgery when you can prepare. If they have a trauma, here's how you manage it. But you got to get in there early. You can't let it linger, and don't take the wrong, don't misstep, don't misdiagnose the mental health opportunity and treat it with opioids. Essentially, that's what was happening, and we were creating iatrogenic misuse disorders, and we were missing the diagnosis of misinterpretation of symptoms, post-traumatic stress, worry, and despair about the future. So when we gave people the tools to say, set department limits, set practice limits, and then say, I wish I could give you more, but it's against the rules. Let's talk about what we can do. It just makes it so much easier. So I think people are embracing it as they see that it helps them and their patients.
Yeah, absolutely. And that's the way I look at it. And as you're saying, I think most of us in this, on the medical side is that we want all of our patients to succeed. We want to be able to prescribe them good medicine, whatever field we're in our circumstance, surgery. And it's frustrating for all parties when things don't go well, and having this understanding that there are factors out of our control, things that we may not understand, but are obliged to learn more about, because if you're operating on somebody and you don't pick up some of those clues you were mentioning, somebody's coming in with a diagnosis of carpal tunnel syndrome, which you've seen a million times, and the symptoms are way overblown for that. It kind of perks up your ears. There's a little bit of a red flag there that makes you think something's not quite right here. And if you don't take that time to think about, is something else going on here, you might find yourself and the patient in some trouble.
Yeah, what I'm thinking about is every patient has a mental health opportunity. So like people think about what you do for yourself. Like, when do you go to the doctor? I think most of us don't go to the doctor for a symptom. Like, we have a lot of symptoms, and then we just, let them run their course, and we reassure ourselves about them and we move on. And I think the average human being does that. So it's not a symptom that brings a person, it's a symptom that's become a concern. Mm-hmm. And the moment that it becomes a concern is the mental health journey right there, because it's usually based on a misconception. So I think about, this is a sports podcast. Like, we're talking about elite athletes rupturing their ACL and trying to get back to sport, or dislocating their shoulder, trying to get back to sport. That's actually a small part of your business, right? You're seeing people with knee pain in their 40s and shoulder pain in their 40s. Yeah. That's who you're seeing. And so you're seeing MRIs diagnosed as tear. And those are not tears, those are gray hairs and thinning. And that's and so you're just, it's a setup. It's an absolute setup. So you're taking a person, remember, someone who's losing their identity, mm-hmm. someone who's interpreting the pain as a new injury and something that needs to be fixed or repaired, or they won't be able to do all the things that matter to them. That's what they're bringing to you, that concern. And what you have to tell them is, well, you have to correct a lot of misconceptions. That pain is new, but the problem's not. Right. It's a degenerative problem, not an injury. Now, I would never say it this way, right? I would never, ever say it. This is how the old David Ring said it. Right. It didn't work. So I do say that essentially we're bringing people from injured to old. But when I say that, my colleagues shrink, like, oh, it sounds so awful. But that is what we're doing. But you can't just say it like that because it sounds so awful. But that's what you're doing. So you are always, like almost always, dealing with misinterpretation of symptoms to some degree. It's impossible for our mind is a worst case preparatory machine, storyteller, and so you're almost always overcalling it. And then when people get the sense that they're injured, there's a lot of things to reinforce that, and undoing that will be hard. But the idea that accommodation is a good health strategy is not what people are thinking when they see an orthopedic specialist. But it is. Accommodation is the best thing. And I would say, again, it's an ethical dilemma. If you don't help a patient explore accommodation, first of all, you're letting them down, because you can't, ACL reconstruction is not like a native knee. And, rotator cuff repair is not like a native shoulder. And so that part of their journey, that accommodation part, You don't want to miss out on that. And if you emphasize that and prioritize it, a lot of times they go away, they don't want surgery. So if you look at people with new shoulder pain and you do MRI or ultrasound, you see something small, small defect, and you look at, there's a lot of studies coming out now, 5 years later, how are they doing? Most of them, they're fine. Now, I don't know if they have zero symptoms, but they're not thinking about their symptoms. So they are asymptomatic in that way. But there's actually one Korean study where they said, are you sure? What about this? What about that? And they found some shoulder symptoms. So they're there, but they're accommodated. And then you look at their MRI or their ultrasound, and a lot of them, a certain number of them have a little bit larger defect, but surprisingly, many of them don't. And so we don't know the natural history of the pathology. We know the natural history of the illness is people tend to accommodate it, and it tends to regress to the mean or feel better, or they just accommodate it. So when that person is in your office, that's not how they're thinking. That's not what brought them to the office. They're thinking the exact opposite of that. I'm screwed unless you do something.
Right.
It's hopeless. That's what people are bringing to us. Now, I'm overstating it, but there's some small element of that which brings the person to the office, and you have to honor that and anticipate that and help people feel more reassured and guide them towards, hey, that's how it seems. Definitely, we all feel that way when we get our symptom, but the outlook is good. The outlook, and I have to sometimes say, I know that I worry about this sounding dismissive. I really don't want this to sound dismissive.
Right.
But I really do feel hopeful for you. And I feel like there's a real reason for hopefulness. But I know that people often encounter my hopefulness as this kind of dismissiveness about what you're going through. That's not what I'm saying. So I'm very, you have to name the emotion that you can almost see it on their face as you start to say, I think I have good news.
Yeah. And I mean, part of medicine is sort of being that improv actor, because you take 5 different people with the same pathology, 5 different people with a rotator cuff tear, and they're going to come in with 5 totally different mindsets. Some want surgery no matter what, some don't want surgery no matter what, and everything in between. And so you kind of have to react on the fly. I think, it's like you react to the defense. You just, you play the way what they're giving you. Yeah.
Yeah. You meet people where they are. And that's a key communication strategy. And that's, again, the medicine's easy. So in your mind, you're thinking there was no major injury event and the exam doesn't show any lag signs or weakness. So that rotator cuff's in pretty good shape, most likely. And so you're thinking the medicine's pretty easy. Let me navigate the story. Let me navigate their experience of this symptom. And I think you got to prioritize that and prioritize the relationship, the trust, the compassion. Call that compassion, where you say, you didn't come to, it's an effort to come see me. You're a little unsettled. And then that doesn't feel good.
Right. So speaking of, folks we see in our own practices, I don't see Naomi Osaka, I don't see Kevin Love or DeMar DeRozan, but we see a lot of particularly youth athletes, weekend warriors, with our elite athletes coming out with more openness about their mental health struggles. Do you think this will increase in awareness on our athletes who aren't on TV, on our athletes who are in high school just playing for fun or shooting for a scholarship or what have you? These days, there's what we call this sports specialization. Back in our day, we were playing 3 sports. It was soccer part of the year, basketball, baseball, et cetera, et cetera. Now it's, I've got the 12-year-old pitcher who comes in. He's got his own coach, a hitting coach, a pitching coach. He's playing year round. It's a lot of pressure on these young athletes. And that takes a toll, both physically, as we know, and also mentally. Do you think seeing our role models, our elite athletes, kind of come out from the shadows and say, hey, I'm not necessarily totally okay, will that help our younger athletes, this next generation, to be more upfront with their own feelings?
Yeah, it definitely gives you a sort of a role model or a place to point or a story to tell, to get them thinking in a new way. But I'll tell you, it's like I told you I had a psychologist in my office in Boston. I have a social worker in my office here in Austin that can do some cognitive behavioral therapy. And And you could bring out that story of Naomi Osaka or something, but you better be careful when you do any of those things, because what I teach people is don't invite the social worker in until the patient requests it. And don't necessarily bring in the mental health story from a prominent athlete until the person is opening the door. Yeah. And the way to get that door open is motivational interviewing techniques. So the key elements are open-ended questions, affirmations, like how do you do it? I mean, you're such a high-level athlete, even though you've got this sore elbow and you've got this change here, but you're able to really perform. That's pretty impressive. So that's an affirmation. You're adaptive, you're accommodative, you affirm the things that you want to see more of. And then there's reflections. And a simple reflection is your elbow hurts. A complex reflection is you're worried you're going to not be able to be the pro pitcher that you want it to be. That's a complex reflection. And you say it just like that. You say a statement rather than, is it that don't make it a yes or no question. Make it a state. You say the statement, and then they can say, no, that's not it. I don't really care if I'm ever a pro baseball player. No, they can correct you. So you say it flat without a question mark, and then they can correct. It invites them to tell you more. So, and then the last one is a summary. So if I'm hearing you right, it's this and this and this. So you use those techniques, all of which will get them more comfortable with you, and all of which get them talking. And then as they start to talk, the misconception will come out, or the worry or the despair will come out. And then you can notice that. That's the empathic opportunity. When it comes out, you notice that and you normalize it. That's how we feel. That's how athletes feel when they hit this moment. It's exactly how it feels. And then you can start to reorient it, gently reorient it. And then when they start to say, yeah, I wish there's just these thoughts that I can't seem to shake. It's like, well, that's where like so-and-so professional athlete as a sports psychologist, that's why they're there. Because it takes just as much training to get your mind in the right spot as it does to get your body in the right spot. But you got to kind of wait for that moment where you kind of knock a little bit and then they open the door. Sometimes you knock and they go, bam. Yeah. and then you retreat to empathy. You try to get out of the room that moment, make an exit strategy, and then resume the conversation later. Because it'll be a different conversation on a different day most times. So you don't want to they want you to solve everything right away, but remember, it's soothe, not solve. So you hit the wall. You're not going to get anywhere more. You're not going to get anywhere today. Yeah, they're very fixed in the way they're thinking and where they've got their hope invested. You need to get away or find a way to get another day. Maybe call them tomorrow, talk next week. Right. Whatever you can do. Maybe next month, if you're lucky, you can get it out to a month, and then you gotta use that. Atul Gawande called it incrementalism. So you incrementalize the care. People are there. You got to fix me today. It's already too late. It's taking too long. It's like, I understand. Give me a little bit of, let's take a little time and space on this one. And let's there's a lot to reflect on just so far. I think you need some space to sort this all out. Then we can talk about it again. And that generally works. I've had to beg people for that space. I said, it's for me. You're doing a favor for me. And I apologize that I have to ask this of you, but I need it. Yeah. And sometimes they're just pushing me, and I've had it work. And then the next day the conversation is completely different. Yeah. Show a little vulnerability.
Yeah. Going back to sort of my ACL example, I like to have that conversation about the expectations, particularly for the teen athletes with their family, with their parents, because a lot of times you can tell there's this external pressure from the parents, like, he's going to play, he's going to get the surgery, and he's going to play because we're counting on him getting a scholarship to Stanford. And he's going to be the next Justin Verlander. And, that's just not real life. There's only one Justin Verlander out there, and there's a reason why. And so I think setting that stage so they know, the recovery is individual. There may be bumps in the road. That's okay. We're here to support you as best we can. Having the parents hear that too, I think, can be helpful, especially for these teenage athletes.
Yeah, let me ask you about this. I think it was the Midwest Orthopaedic Association meeting in San Antonio a couple of years ago, and the talk before mine was a sports medicine talk by a community guy, not an academic. It was the best talk I ever saw because he talked about all that stuff, and he said stuff that I've been saying for years.
Yeah.
As an elbologist, I do get pictures now and then. Mostly they went to the sports guys at MGH, but I would get them now and then. And many times it was, my buddy had a Tommy John, and he can throw 5 miles an hour quicker, and he's still a prospect. I need to get that surgery.
Right.
And it was the fading dream. It was the fading dream. It's the loss of identity. And I've been talking about that. Because if you look at, we did a paper where we reviewed everything published that we could get a measure of pathophysiology of the pitcher's elbow. So MRIs and X-rays before Tommy John surgery. There was a screening of Major League Baseball pitchers. We just took whatever we could get. It wasn't a lot. But what we found was that people that were having surgery and people that were not having surgery had elbows that looked about the same.
Uh-huh.
And so I believe that you cannot be a professional baseball pitcher without having lax UCL and valgus extension overload arthritis. And so they all have it. Every single one of them has it. And every single one of them, their elbow hurts to some degree every day, and their shoulder probably the same. But so it's not that that's keeping them from being effective. It's all that other stuff of accommodating that and still keeping focus and still being smart about how you do things. The story about Tommy John is that the first time that surgery was done, they buggered up his ulnar nerve, and his ulnar nerve was never the same.
Yeah.
So what's more important to pitching, your grip or your elbow? I think it's your grip. But he found a way, right? He found a way to get through that and still pitch at a high level for years. And that just shows you it's more about smarts and resiliency and adaptation and accommodation of problems. I don't think that gets its due. I don't think that doesn't get talked about as much as it could be talked about. And particularly for that high school athlete, that there's just almost no way in hell they could ever have worn their UCL out yet. That's not the issue. So I saw he talked about it right up front, and I was pretty impressed about that. Yeah.
Well, David, this has been great. Thanks so much for spending time with us. Can we finish off with 5 questions with David Ring?
Sure.
All right. So you grew up a San Diego Padres fan. I got my San Diego hat back there somewhere. And you still follow them today. How do you like your chances this year?
It's so up and down right now. But I mean, it's going to be the Red Sox years were good. And I can tell you that what you need is everybody to stay healthy and perform well.
Yeah.
Make a couple of key moves at the trading deadline and bring up a couple of people from your farm system. And when that, and then you need one or two, you usually basically need 2 really great pitchers that are pitching their best at the right time. So I think they have as good a chance as anybody else. They're stacked, and the farm system's stacked. So I think it's a little bit of luck once you get down to the end there that all those things align.
Yeah, I'm a Oakland A's fan, Billy Beane disciple, who always says it's a crapshoot. A's haven't advanced very far, even though they've been in the playoffs a lot. And so we'll just leave it at that. Who's your favorite Padre of all time? Side question.
Of all time? Yeah, I would say probably Dave Winfield.
Oh, yeah. All right. Okay, question number 2. Better Mexican food, San Diego or Austin?
Yeah, that's funny because, the Mexican food is nothing like it is in Mexico. I travel a lot in Mexico. So it's like
better Mexican food, San Diego, Austin, or Mexico?
There was this place in Boston, La Taqueria Mexicana in Union Square. It's probably still there. If you go there, that guy, just get the tacos, and they're, it's like just right off a taco cart in Mexico. But no, so San Diegans, it's the carne asada burrito. Mm-hmm. Like you get off the plane and you go to Roberto's and get a carne asada burrito instead of going to see mom later. So I'm still addicted to that. In in Austin, it's all about the tacos and particularly the breakfast tacos.
Oh yeah.
But it's more about tacos, and you can't go wrong really. But yeah. So and then I'd call it even.
Okay. All right. So as we said before, you are a musician, and from what I understand, you play multiple instruments: guitar, bass, and drums. Is that right?
Yeah.
Yeah. You played in some bands in Boston during your time there, and it sounds like you're playing in at least one band in Austin.
Yeah, I started playing when I was kind of, I think everybody dreams of being a rock star. So I finally got my mom to let me rent a drum kit. I didn't know how to make it quiet. So 3 months later, the neighbor said nope. Yeah. And then I sulked for a while. I was scared of guitar because that was the Eddie Van Halen years. I thought only deities played guitar. Yeah. So I picked up the bass guitar, and then I got pretty good at that. Even started playing a little bit I played with a few guys a little bit. And then somebody on my street, I was talking to him at the 4th of July party. He's like, oh, you should come take the guitar that my daughter never used. So I started playing guitar. And then in high school, our senior year of high school, we formed a protest band. And it was all punk and 50s stuff. And then, so we all played each other's instruments, and we didn't, it was sort of real punk attitude. And then kept playing in bands. In my 3rd year of medical school, we actually got on the radio. I was the drummer in the band, in that band, which had a really good singer, songwriter, and recorder, and we got on the radio a little bit. So that was about it. And then when I got to Boston, nothing, busy in residency. But then when I was a fellow junior attending, a class of residents had 3 people that played. And so we made a band, and the name of that band was Rod the Long Bone. So just had to explain that a little bit. But and that band, I went back to Boston 5 years ago. We played, got together and played a little bit. But and there were a couple of generations of that band. And then when I got to Austin, I met the chief of psychiatry played, and one of the people there's 2 groups that take care of the musicians in Austin. A lot of professional musicians. And there's HAM, Health Alliance for Austin Musicians. That's basically all medical and dental stuff. And then there's SIMS, which is looking after mental health and substance misuse. And the clinical director of SIMS was a drummer. And so I was hanging around them a little bit. And so I knew who our drummer would be.
Yeah. Very cool. Well, the question was, did you aspire to be a rock star? And you answered that. I play acoustic guitar, and I still want to be a rock star.
I realized though that I probably, I'm probably not well suited to it. Like one of the things I noticed is like we would play 6 or 7 gigs a year for charity and stuff, and we'd get sick of our songs. And I thought, what if you're Aerosmith and you're still playing Sweet Emotion 200 nights a year for the last 30 years? Yeah. I used to say, jokingly, that's why they do heroin, but it is, I mean, you have to be a performer. And if you see Steven Tyler, like he's a performer. I saw him on like American Idol, and he's just a performer. He'd break out in song, he'd sing with people. He's got, I don't have that. Yeah. I love to play, but I'm not a good performer. Yeah. So I think I found my niche. Yeah. My problem is that I like to be in bed by 10 p.m. So yeah, exactly. All right. Well, it's not quite walking up to the plate or coming out of the bullpen, but there's a small amount of excitement when you're, freshly clean hands and walk into the OR. You're about to get gowned up. So if you had to choose one song as your entrance music into the OR, what would it be? Oh, I would, my favorite album is Back in Black by AC/DC. Oh, yeah. So I'd probably go with Back in Black or Hell's Bells or something like that. Yeah. That'll get you pumped up for a carpal tunnel release. All right. Question number 5. What advice do you give to your trainees, whether it's a medical student, resident, fellow, what have you, when it comes to understanding and appreciating mental health? Yeah, I guess here's how I'll say it. And I'll give a story. I had a high school student shadowing me on telemedicine the other day.
Mm-hmm.
And so
how does that work?
He knows. Oh, I go into the room and I say, hey, do you mind if I have a student shadowing me? Do you mind if they come in? I've never had anyone say no. They always say yes. They say yes before I'm done. They're like, people love to, you know how this is in a teaching hospital. They love having learners come around. They sometimes complain later. Like they think some of my complaints were like, oh, I was performing for his audience. But for the most part, they really like it. And they really enjoy it.
It's telemedicine, or they're
so it's like Zoom.
Okay.
We're on Zoom, and they're just one of the people in there. It's been working really great. I do undergraduates love to shadow. I'm like, come do research. Don't just shadow. And I get a lot of them doing research too. So, but so anyways, this high school student's watching me, and I say, "What did you notice?" I always say that. What did you notice? But this high school student knows nothing about medicine at all, and he noticed everything. He was able to describe, I noticed this, and he noticed all the human aspects of it, the worries, the misinterpretations, the loss of identity. He could name it, he could notice it. And I said, this is what I say to medical students and residents. I say, if you're a fresh medical student, I always say, you're still more human than doctor. Try to hold on to that. Don't let them dehumanize you.
Yeah, right.
And I described my own journey as I kept this pilot light of humanity, and I cherished it while they were dehumanizing me in orthopedic residency and medical school. And then when I started doing this, patient reported outcome measure stuff, started to bloom.
Right.
But you're more human. You always want to be more human than doctor. That's my advice.
You're like that scene in The Grinch when his heart
started to... My heart grew 3 sizes. Yeah, absolutely.
David, I really enjoyed speaking with you. Thanks so much for coming on the Sports Medicine Orthopod. Thanks to the audience for tuning in. Please give us a like and subscribe, and we'll see you next time. Thanks so much.
Thanks.
Hey, folks, thanks for tuning in. If you like the show, please subscribe, like, and share. And we'd love to hear from you. If you have a question about today's show, or you, a loved one, or maybe your favorite athlete has sustained a sports medicine injury that you would like to know more about, please reach out to us on Twitter, Instagram, Facebook, or email. And stay tuned for more exciting content from the Sports Medicine Orthopod. Thanks again.